Now, there are secondary factors that become important. Was there hospitalization, surgery? Did they go by ambulance? Are they treating by other medical providers? All of those are definitely important, but they become significantly less important. I mean, let's face it, if you have hospitalization or surgery, even if they went to the ambulance, and there's no objective findings and there's no permanency, in other words, the person's healed 100%, you don't have much of an injury reward there. So we'll show you that when we actually go into the transformation of the documentation into the injury awards. Now, what needs to be highly aware or talked about right now is not just these 7 categories. So there's definitely more, like I said, injury magnifiers, complicating factors, medications. So there's definitely other components that help to build it. But this is the bare 7. This is the skeleton of a strong case. Now, there's 5 top financial driver categories. You've heard of Colossus, the injury software. There's essentially 5 major financial driver categories. Let's cover each of these first. Then there's 4 categories to defend the case. And then there's the one kind category of how to put it all together, because that's real important. Both. I always say, you can have bad documentation and good delivery, and it'll significantly help your case. You can have great documentation and terrible delivery, and it'll significantly hurt your case. And of course, the goal in what we do with the Car Injury Doctor Network providers is both. We want high sensitivity, high relevancy documentation, and then deliver it in the best possible format. And that's what we're going to cover right now. So let's start with number 1. Out of these 10 categories, I found that these are the 10 most important categories that are going to affect your injury award. So number 1 that's the absolute most valuable one relative to an injury award, and it's the injury diagnosis. Now, we already said we're going to start with the disc. We already said we got a positive MRI, okay? By the way, where does that relate into the scheme of personal injury cases? Well, according to the Insurance Research Council, okay, 87% of the cases are soft tissue injuries. So that's the majority of them. 80% of the cases are low impact, under 20 miles an hour. So the vast majority of all of these personal injury cases are not what I call, dead baby cases, huge cases. They're not. They're soft tissue injuries is what they are. 80% of them are under 20 miles an hour. Now, 32% of them are disc. Now, this is right from the Insurance Research Council. 32. So 2/3 of the personal injury cases are not disc, they're soft tissue. 16% are nerve, 10% are mild concussion, 2% are fracture. So the vast majority are soft tissue, and then 1/3 of them are the disc, okay? So having said that, that kind of puts a perspective on volume and what we're dealing with here. So injury diagnosis. Well, most attorneys go, okay, I got a positive MRI. Good. I got a good case. I'm done. Let's go. Well, watch this. When you have that injury diagnosis, here's what's happening. This is where the start of losing 50% of the injury award starts, right here. When you have a disc injury, a disc bulge, a disc herniation, those are ligamentous lesions in the disc. The disc is essentially a gelatinous tissue with ligaments around it by the 2 bones, okay? When you have that disc bulge, you've injured that ligament, that disc ligament. You go, well, why is that important? Well, it's important because the main injury and the most valuable injury is not the positive MRI. It's called ALMSI. It's a ligamentous instability. That's way more valuable than a disc bulge. And we're going to go through and we're going to show you how and why right now. So here's what's happening. When the doctors are getting positive MRIs with disc bulge, they're not evaluating the ligamentous integrity. And if you do have a disc bulge or disc herniation, it's like a 97% chance you're going to have a ligamentous instability. Now, it's called alteration of motion segment integrity, altered intersegmental spinal motion. In other words, it's the ligaments that hold the bones together of the spine, right? And you go, well, why is that so important versus the ligaments of the pinky? Well, 3 major reasons. The spine is the major structure of the human frame. It's the most responsible for the most mobility of the human frame, human body, and it protects the central nervous system. So there's tremendous way more value in a ligamentous lesion holding part of your spinal column together than, say, the digit on your pinky. You tear a little bit of your ligament on your pinky, depending on what work you're in, could be no big deal at all. You tear a ligament in your spine, you now have permanent instability. Now, I said the word permanent. Ligaments are not like rubber bands. Once they're torn, they're torn. That's it. As a matter of fact, you don't even have to go through the 3 phases of healing. That's it. It's torn. It's torn. That's it. Now, one of the pictures that your doctors should have is this right here. This picture represents the ligaments, and you can see this is an electron microscope. You can see the ligaments that are all striated. This is all normal on the left side here. And then on the right side, this is what it looks like when you have a ligamentous lesion. These micro lesions in the ligament. Now, what does that do? It causes instability in the motor unit. A motor unit's two vertebrae. Now, when does that become important? And who says that's important? Well, take out the next sheet here. It's a sheet right here. Loss of motion segment integrity. This is right from Doctors Panjabi and White, who wrote, they're essentially the fathers of spinal biomechanics. They're the authors of Clinical Biomechanics of the Spine. And if you're a personal injury attorney, chiropractor, doctor, that's definitely one book that should be in your library. And so he goes in to define it. It's the most comprehensive research on spinal mobility, static and dynamic. That's what it is. It's the authors. So what happens is when you have these injuries, forward or back, in other words, these micro tears in the ligaments, depending on which ligaments it's at, it allows for more movement within that motor unit. So the only way you can detect this, an MRI will not detect this. It has to be stressed. When you're evaluating ligaments, you have to stress it. You can't take a neutral X-ray either. You have to stress it. And you have to stress it in a certain direction to test certain ligaments. Just like if I'm lifting weights, if I want my biceps to get better, I got to do biceps. This isn't going to help my triceps. So if I want my triceps, I got to work on the tricep. So there's different X-rays of the neck, whether it's bending forward, bending backward, tilting to the left, tilting to the right, opening the mouth, tilting to the left, tilting to the right. All of those are what are called stress views. They're dynamic stress views. And we're looking at the integrity of the ligaments. We're seeing if they're torn. And that's what this is. So in the neck, you can have translation where it slides on one or another. If it's greater than 1 millimeter, it's pathology. If it's angles greater than 7 degrees, it's pathology. If it rotates abnormal, it's pathology. Up in the upper ligaments in the atlas and the first and second bones in the spine, if it moves more than 1 millimeter, it's a pathology. It's a permanent pathology. It's intersegmental instability is what it is. Now, this gets to be very important as we move along here. So you have to ask yourself, if you're getting a positive, in other words, what should have the doctor have done when he got a positive MRI for a disc bulge or disc hernia? He should have done a ligamentous instability stress test done with X-rays. Now, when I say motion X-rays, I am not talking about fluoroscopy. That is not it. I'm talking about motion studies where you bend as far as you can, take the picture. Bend as far as you can in another direction, take the picture. In other words, you take that joint, you stress it, take the picture. And then you look, we actually measure, are the bones still in a line or are they moved? And they shouldn't move. They've moved, you got torn ligaments. That's the simplicity of it. And it's 100% objective. It's not a hybrid test. It's not a subjective test. It's 100% objective. And you'll find it in about 70% of the cases, even more so if there's a disc bulge, because the ligament's already torn. So you're at a 95 to 97% chance of getting ligamentous instability if the doctor just did the test and gave the diagnosis. And it should be the primary diagnosis. The disc bulge would be secondary, not primary, and you're going to see why in just a second. So it's called, depending on the ligament you're looking at, but we look at the ligaments. We'll look at forward, angulation, translation, lateral flexion. We're going to take that spine, we're going to move it in all these directions, take the exercise, and we're going to see if there's some some ligament damage there. Now, what becomes important with this is a lot of times these patients who have a disc bulge, they can't move all the way in a particular direction because of the pain. Well, if they can't go all the way in a particular direction because of the pain, that's not stressing the ligament. So we won't. So what needs to be done, if that's the case, now we have to include pain management, and we either have to have them take some prescription analgesics or even some micro shots, analgesic shots to numb them up so we can move the head as far as possible, take the picture, move it backward, take the picture, move it to where they're not screaming in pain. And sometimes we have to do that. And of course, that's when you find the problems. But that's not being done. So the first question is, are your doctors doing that? Are your doctors doing the ligament stress test when you're getting a positive disc bulge or disc herniation on an MRI? Well, if you're not, you're 0 for 1 right now. And you're missing out on a much greater injury award than the disc. And as we go through this, you'll see it. Okay, let's go to number 2. The second most important injury award category is the impairment. Remember, we talked about, if you get injured and you healed and everything's normal, there's not much value in that. Well, it is if it's permanent. Well, a disc, by the way, is permanent, but also a ligamentous instability is permanent. But here's the difference it makes. And doctors, if you could pull your AMA impairment guide out. If you go to the AMA guides for impairment, and let's look at the typical impairment for a disc. Let's just look at a cervical disc. No residuals, no tingling, numbness, weakness. Let's just say a disc bulge, disc herniation. We're just going to keep it plain Jane, okay? So what's the impairment for that? 5 to 8%. Now let's say the doctor actually did the ligamentous stress test and we have ligamentous injury and it's established on x-ray. What's the impairment now? 25 to 28%. You went from 5 to 8% to 25 to 28%. That's the importance of knowing how to document it. Now, that's number 2. That's the impairment. So again, is your doctor giving you an impairment rating for the disc? Well, that's fine, but that's not where it's probably at. They need to do the stress test for ligamentous instability. That's where you're going to get the 20, 25, 28% impairment rating, not the 5%. Let's go to number 3. So you have to ask yourself, are you getting that right now? In other words, are you 2 for 2? Are your doctors doing this right now? Are you 2 for 2? Well, most of the time when I give this seminar and I ask the audience, they're usually 0 for 2 right now. Number 3, and I'm going to combine number 3 and number 4 because now we're talking about activities of daily living. So the loss of enjoyment of lifetime activities is the 3rd most important financial injury award category, if you're not aware of that. The 4th one is what's called duties under duress. Essentially, what we're doing is evaluating the permanency of activities of daily living. That's what this is. These are called impairment indexes. Now, you can't give them if you don't have an impairment, okay? Now, this becomes real important, and let me just take a step back. Remember we talked about the 4 injury awards? Remember we said one of the injury awards was an impairment injury award? Well, if your doctor's not even doing the impairment rating, that injury award's checked off. It's not even being given. Now, there should be for the disc, that is an AMA guide-based impairment. Okay, so here's what's important about this that's commonly missed. Number 1, the doctors typically don't do it because they don't have an impairment. Number 2, they're not familiar with it. They haven't been trained in it. If they do give you something about activities of daily living, they'll say, well, it's only for 3, there's ADL restrictions for 3 months or 6 months or something like that. No, that's not how it works. This is permanent. So number 1, you can't give it unless you have an impairment rating. And then when you do, this is medically accepted. This is what you use for the ADLs. These are called impairment indexes. Now, the last piece of this puzzle that most attorneys don't know, and most doctors, matter of fact, don't even document, is most of the pain and restrictions are in the last two ranges of motion. Let me say that again, because that is huge when it comes to personal injury, especially low impact soft tissue spinal injury and disc injuries. We have three ranges of motion. When I move my neck, my shoulder, my elbow, there's three ranges of motion that we have. Number one is called active range of motion. Well, that's what we can do on our own. In other words, if I take my elbow and bring it up, that's my active range of motion right there. I can't go any further. That's it. But after I go as far as I can take an external source like my other hand and push it further. Now, I couldn't do that on my own, but I can with an external source. That's called overpressure range of motion. And then once you go past that, it's called paraphysiological space joint motion. And that's the motion that is seen on the x-rays. So this is evaluated by the clinician, the patient doing it on their own. Overpressure, the clinician actually has to move the patient to see if they have it and if there's any pain or restrictions. And then to find the joint motion pathology, that's motion x-rays. That's how each of the three ranges of motion are documented. Now, why am I pointing that out and why am I putting so much emphasis on this? Because that's where 80% of the positive findings are. They're in overpressure joint motion, not in active range of motion. Now, with a disc, a lot of times you will have a permanent impairment with some restrictions in active range of motion, and it's typically in the plane of injury. That is true. But the vast majority of the problems are not just in active range of motion. They're in overpressure range of motion and in the joint motion. And I'll give you a real life example with the case that I was sharing with you with the lady who was injured with her low back. So she has this personal injury in her low back. Well, she could move, generally speaking, 10, 20 degrees, no pain. What she could not do is bend over and pick up her laundry basket or her 6-year-old child. Why? Well, when she bent over that far and she picked up weight, that took her back into overpressure range of motion. She couldn't do it on her own. We can't go into overpressure range of motion on our own. So she couldn't do it. That's where the problem was. And in joint motion, neither one of those were documented by the doctors. The emergency room doctor and the general practitioner only evaluated active range of motion, and it was normal, and I testified it was normal also. And then I also testified they didn't even do overpressure range of motion and the test, and they didn't even do joint pressure range of motion where they could see the permanent pathology on x-rays. They didn't even do the test. That's what's going on. And it was very easy to show that to a jury. So impairment, loss of enjoyment in lifetime activities. This is what's not getting done. So typically, at this point, when I typically am talking to doctors and attorneys, usually they're 0 for 3 right now. Usually they're not getting this done, but they're usually getting the doctor to say something about activities of daily living, but it's typically not an impairment, a medically accepted impairment index. That's what this is. This is a medically accepted impairment index, which means you can't challenge it. It's medically accepted. So, but they'll say something about it. And I hate to tell this story, but I tell it to drive home to the attorneys how bad some of this is. One chiropractor that joined, he was learning personal injury documentation. And I was looking at his notes, and I noticed that he had 3 months of impairment. I go, well, wait a minute. How did you get that? Because number one, you didn't even give an impairment rating. You can't give an impairment index if you don't have an impairment. I said, number one. Number two, when you do have an impairment, it's permanent. There's no 3 months. It's for life. How did you get that? You didn't have an impairment and you only said 3 months. I said, how did you come up with that? He says, I hate to tell you this, but That's what my friend does. That's what my chiropractor friend does. And I didn't really know why. I just did what he did. See, this is the kind of thing that's going on that attorneys don't even know. And that's the lack of documentation that the attorneys don't even know. Okay. And of course, I told him, I said, never say that again. Okay. So typically right now, most of the doctors are typically, let's say, 1 for 4. They'll say something about ADLs, but it's usually not correct in how they do it. So they're typically 1 for 4. Prognosis and need for future care. Again, you can't have a prognosis and need for future care if there's no impairment. Now, if you do have the impairment, and you should if there's a disc bulge, but remember, if that's all they're doing, you're at only 5 to 8% if there's no residuals. And with all likelihood, that could be, with high probability, 25 to 28%. So you go to the prognosis. So if you don't have an impairment, you can't give a prognosis. Why is that important? Well, the prognosis, remember, is one of the 4 injury awards. And it's usually the larger of the injury awards. That $110,000 that lady got, most of that injury award was for therapy that she was going to need for her low back the rest of her life. That's what it was for. And so for the prognosis and need for future, we'll take the patient at MMI. What palliative care that they need at MMI. So it's all science-based, not the doctor's opinion. What palliative care do they need at MMI? MMI is based on the science of the 3 phases of healing, first. They get to MMI, second. What palliative care is needed at that point? That's supported by the biomarkers, subjective, hybrid, and objective. What was the frequency that when I say biomarkers, I'm talking about tests. What therapy was needed for palliative care? How many? What was the cost of the therapy? That's what the doctor puts together. And he gives it to the attorney, because that's a doctor function. Then he gives it to the attorney, and the attorney looks up the actuarial scale of the life cycle of that patient. And then he'll multiply what was the cost of what was the palliative therapy, how many, what was the cost of it, what was the frequency of it, times the person's until they're going to die, their lifespan. And there's the supportive care, the documented care for the prognosis and need for future care. All science-based documentation. That's one of the 4 injury awards. Okay, we're done now. And so the question you have to ask yourself is, out of these 4 injury awards, how many are you getting? When it's a soft tissue spinal injury, typically the doctor's only doing 1 of 4. If it's a disc, hopefully your doctors are at least giving an impairment rating for the disc. I did a case evaluation just the other day where the doctors put in no impairment rating, but in the notes they said permanent structural impairment, but there was no impairment rating. And then they said they would only be having problems for 3 months. Absolutely made no sense. There was no uniformity to that at all. Okay. So here's the top 5 financial drivers. That's where the money's made. Most of the time, the attorneys are getting 1 out of 4. Maybe if the doctors are giving you an impairment rating for the disc, then you're getting 2 out of 5, 1 out of 5 or 2 out of 5. So right here, this is where typically 2 out of 5, or what is that, 60% of the documentation's not even being done. The doctor doesn't even know because he hasn't been trained in high sensitivity, high relevancy documentation. And there's no way for the attorney to know. He's an attorney. He's not a medical provider. So now let's go into the 4 injury awards. So we got all this documentation. We understand it. We got a strong case. You go, okay, well, what's it worth now? Well, let's look at each of the 4 injury awards. 2 of them are kind of common throughout the United States. 2 of them will vary depending on where you're at. Medicals are totally supported by the science of the 3 phases healing. We go, okay, what are the tests that were positive? what were the therapies that were done and what was the cost of the therapies and how long did that happen? There's this support for the inflammatory phase. We do the same thing for the repair phase. What were the biomarkers, the test? What was the therapy? How long did it last? There you go. Now we have the cost for the repair phase. Do the same thing for the remodel phase. What were the tests that were positive? What were the therapies that were done? How long did it last? Now that's how we substantiated the medical impairment award. Multiply that times 3 to 1 or times 3, and you have your medical injury award supported with documentation, not a doctor's opinion. Go to number 2. Now, the impairment injury award can vary definitely depending on where you're at. And sometimes it's integrated into pain and suffering. So you've got to, depending on what state you're in. But generally speaking, if we're looking at structure, a very simple structural way to explain it to a jury, to make sense to a jury, is this go, okay? It's from the time of the injury. What is the person's average income from the time of the injury until they reached MMI? That amount of money for the impairment injury award. And then again, you can multiply that 3 to 1 also, okay? That's a common way. Then you go to pain and suffering. How the pain and suffering? Well, one way is to do the same thing. What's the typical income from the time of the injury to MMI, and multiply it times a magnifier of 1 to 5, depending on the severity of the problem. That's directly associated with some workers' compensation guidelines. That's one structural way. Another structural way that a lot of times attorneys will do is they'll put a dollar amount per day. They might say 50 cents a day, $1 a day, $3 a day, times an actuarial scale of how long the person's going to live. That's another way that they'll do pain and suffering. And then when you go to the prognosis and need for future care, that's very science-based. We go, okay, well, what were the tests that were positive for palliative care at MMI? What therapies were used because of those positive tests? What was the cost of those therapies? And then you go, okay, well, what's the frequency going to be? Well, the frequency is going to be, what was the frequency at MMI? And then you go, how long? Well, that now goes to an actuarial scale. And that's the science of creating the prognosis and need for future care injury award, not the doctor's opinion. So there's your 4 potential injury awards when you do have documentation. When you don't, when these categories are missed, and one of the big examples that I said, remember when we covered the 10 categories, I said most of the time, only 7 out of 10 of those categories or only 3 out of those 10 categories are documented. If your doctor is giving you an impairment for the disc, then it would be that would be 4 out of 10 that's being documented. So let's use that as a number. So let's say that you're getting 4 out of the 10 categories documented by your doctor. And let's say that the average dollar value per category is $1,000. And it's going to be more, but let's just keep it simple. Let's say it's $1,000. So if there's a potential of 10,000 and your doctor is missing 6 categories of documentation, that's $6,000 a case. Take that, multiply it times the number of cases that you're seeing a month. If you would do that, fill that out, that will show you your potential loss, but it will show you your potential gain when this is done right. I found that the average attorney loses $250,000 a year. That's seeing only 2 or 3 soft tissue injury cases a month. You do the math, the doctors are only documenting 3 or 4 categories. The attorney's losing $6,000 to $7,000 per category. Do that times 3 cases a month. 3 times 7 is 21,000. 21,000 times 12 months is right near $250,000. It happens pretty fast. You lose a lot of money real fast. Go ahead and project that forward another 5 years, another 10 years, and you got $2.5 million just from the doctor who's not documenting high sensitivity, high relevancy cases in only 2 or 3 cases a month. You just lost $2.5 million in 10 years. That's how fast it happens.